Good morning to the House. Today I am going to present the role of FDG-PET CT in biliary tract cancer. Although the subject is related to the nuclear medicine, I don't claim that I will be able to prove too much, but as per orders, right? इससे नहीं होगा. I am there at your service. This is the PET scan machine having table, and it is the front part is CT and behind this is PET. It is also modified in the form of PET MR. This is the machine which is available at ILBS. It is 120 slice time of flight PET CT scan system. This is a cyclotron which produces the FDG, and we receive the cyclotron, the FDG from CG cyclotron Manesar, Haryana. This is the process by which the FDG reacts. This is sorry. एक करके This is about the machine. The process we take, initially whole body CT is taken, subsequently the whole body PET scan is taken. CT takes about 60 to 70 seconds and PET takes about 30 to 45 minutes. And the selection of the desired slides we select. Now, the clinical situation where the FDG take-up is affected, we should have the history of chemotherapy. It should not be taken, the FDG should not be taken before 4 weeks of chemotherapy. After surgery, 8 weeks, radiotherapy, 12 weeks, therapy with the cytokinins and other growth factors for 2 to 4 weeks, rapid acting, short acting insulin after 4 to 6 hours, and intermediate and long term acting insulin 24 hours, and post biopsy at least 1 week should be, one week gap should be there. This is where we inject, this is our hot lab where we inject the dye by taking all precaution to the exposure to the worker as well as to the patient. This is the normal distribution of the FDG in one go. So the maximum number, this is the physiological uptake of the FDG. According to the organ, the brain takes maximum, but due to it is excreted in the urine, the collection of this dye, moreover FDG, I am calling that it is common term dye is used, so it is maximum collected in the urine. Now, we perform the sterilization value, that is SUV is calculated by tumor activity concentration in MBQ by injected dose into body weight. The malignant tumors have an SUV of more than 2.5 to 3. In this case, this SUV is being shown is more than about 8.8. So this goes in the favor of malignancy. However, indications for PET scan in varied conditions. These are the oncological conditions, differentiating from benign to malignant lesion, searching for an unknown primary, staging and metastasis, monitoring effect of the therapy, or response assessment after pre-op, CRT, definitive CRT by distinguish residual viable tumors from fibrosis or necrosis, PET-CT to evaluate any equivocal finding on CCT, MRI on in cases of strong contraindication to the IV contrast, detecting the tumor recurrence, selecting the site of biopsy, and it is also used for guiding the radiation therapy plan. Non-oncological indications are atherosclerosis and infection. Certain conditions can increase the metabolic uptake, leading to the increased FDG uptake on PET-CT. They are infection, inflammation, and infarction. Now, this is the most safe study, which because it is not dangerous to anybody, because it has a very short half-life and the amount of radiopharmaceutical is given in very high, very low dose. The only contraindication is a pregnancy in the female. The estimated dose, the total dose radiation from FDG to whole body PET-CT ranges from 10 to 14 millisieverts. About 50% of FDG is excreted in the urine within 2 hours, and however the estimated radiation to the bladder is very high than other organs. This is role of diagnosis for FDG-PET in biliary tract cancer. It can be used for diagnosis of primary biliary tract cancer, diagnosis of lymph node metastasis, diagnosis of relapse in the treated cases, and response assessment of the treated cases. Now, the biliary tract involvement, there are different sites of the malignancy. It is composed of 3 main different entities: gallbladder carcinoma, intrahepatic cholangiocarcinoma, extrahepatic carcinoma, as shown in the potential limitation of use of FDG in patient with biliary tract carcinoma may be the false positive results related to the biliary stenting, biliary sepsis, and local infection, making difficult interpretation of FDG-PET results. It is less helpful in infiltrating periductal tumors, and for perihalar lesions, the interpretation can be difficult as areas of inflammation may be increased uptake and desmoplastic areas of low cellularity, which may lead to a false negative results. Review of literature. This study was conducted to evaluate the diagnostic and prognostic role of metabolic parameters of PET-CT in patients with ICC in comparison to the conventional imaging system for nodal and metastatic lesion. The patients were included in 76. The metabolic parameters were measured in the form of SU max, SU peak, SU mean. Metabolic tumor volume was also computed was using the threshold SUV is equal to 2.5 by an automated software. The total lesion glycosis TLG was calculated by MTV into SUV mean, and glucose corrected SUV was by SUV max into blood glucose upon 100. Cutoff values were calculated by ROC analysis curve, and overall survival was calculated on compared using the Cox proportional hazards regression analysis. The median follow-up was 55.4 months. Lymph node distant metastasis and prognostic value were analyzed. In lymph node metastasis, in this study, FDG-PET-CT shows higher sensitivity than the conventional imaging modalities in detection of the regional lymph node involvement. It was 74% by 61%. The p-value was 0.13, which is highly significant. Out of 76 patients, 32 patients were having distant metastasis at the time of evaluation, out of which 6 patients distant metastasis was identified only by FDG-PET-CT, resulting in alteration in the therapeutic plan from surgery to the chemotherapy. The prognostic value was also analyzed. The patient with larger tumor size, more than 5 centimeter, higher T stage, lymph node involvement, advanced stage of 3rd and 4th, and inoperable tumors had a shorter overall survival. And for metabolic parameters, patient with higher SUV, higher SUP, higher SU mean, higher SVU glucose, and higher TLD glucose, the significant short survival was noted. This is the Kaplan-Meier curve, which is indicating the results of SU max, SU peak, SU mean, SU glucose, TLG glucose, and operable and non-operable tumors. In SU max, you can make out when SU max was more than 7.3 or less than 3, the survival was increased. In less than 7.3, and same in the mean also, peak also, and mean also. And the same is here with TL glucose and operability and non-operability. This was a robust study which is conducted, and it is the best in the world. A total number of 2,125 patients were included from 47 studies. The study explored the test accuracy of FDG-PET as diagnostic for diagnosis of the primary tumor, lymph node invasion, distant metastasis, and relapse of the disease, to explore the changes in the management based on the FDG-PET, and impact of the maximum SUVX was analyzed and with prognostic assessment. So, in this, result shows that primary diagnosis of the tumor was sensitivity was 91%, and lymph node with specific sensitivity was 51%, lymph node invasion was 88%, and specific sensitivity was 69%, distant metastasis was 85%, and specific was 89%. The relapse was 90% and 83%. This is the forest pool graph, in which various studies were included, and the pool population was analyzed for the change in the management seen. In A, it is showing that there was a change in the management in 15% of the cases. In B, the change in management in the pre-surgical setting was seen in 17%, and change in management in the post-surgical setting for assessment of relapse was seen in 14%. The effect, the survival analysis also analyzed. The effect of SU max overall all survival were worse when the OS value was very high. The effect of SU max on disease free was the effect of this was not informative, but the effect of SU max on progress free was also not effective. This is the flow chart of current clinical pathway for biliary tract malignancies, which was published in the same journal. So, imaging, the FDG-PET has overall, when conventional radiation is conventional diagnostic system is failed, the FDG-PET should be included. In conclusion, the positron emission tomography scan is using FDG-PET fluid. FDG can help in identifying areas of cancer in the body by highlighting the hot spots. These hot spots cancer may be true positive, but may also be non-cancerous like inflammation and false positive. The PET scans are useful to assess how the advances cancer by assessing the spread of the lymph glands and other glands, and also the identify if the cancer has recurred, for the example in surgery, thus helping to make treatment decision. However, a biopsy is the gold standard. Here it is very important. The biopsy remains still gold standard for diagnosis of biliary tract cancer. These are the NCCC guidelines. The PET has limited sensitivity but high specificity and may be considered when there is an equivocal finding. The routine use of PET-CT in the pre-operative setup has not been established in prospective trials. Although the PET scan has not been established in the evaluation of the patient with biliary tract cancer, emerging evidence from the retrospective studies indicate that they may be useful for detection of radiological focal lymph node, distant metastasis disease, and false positive results are related to the inflammatory. They are problematic. ILS data. Number of FDG in January to present time, biliary tract cancer was 350. The carcinoma of gallbladder 135 and cholangiocarcinoma 74, and follow-up cases were 93 and 48 are cholangiocarcinoma for follow-up and staging. Future. This is the latest paper published. Additional value of the integrated FDG value when with MRI for evaluation of biliary tract cancer in comparison to the conventional PET-CT. In this, the PET MRI add value to CT in patient with biliary tract cancer, both in initial workup for staging and determination of overall resectability and follow-up of the local recurrence. This is a very important paper which was recently published. The advantage of 18 FDG, this shows the advantage of gallium FAPI versus FDG PET-CT for tumor staging and biliary tract cancer. Here is the example. This man was imaging, showing images in a man with resectable gallbladder adenocarcinoma with 18 FDG, revealed no abnormal uptake, suggesting the remission. But when it was examined by gallium FAPI PET-CT, images show tracer uptake in abdominal muscle, peritoneal and mesentery and the liver, suggestive of extensive metastasis. This study is very important, that if this radioisotope can replace the use of FDG in the form of early diagnosis. Recently, gallium 68 label fibroblast activation protein inhibitor has been introduced as a promising oncology tracer targeting cancer-associated fibroblasts, which are predominantly component in the stroma of the epithelial neoplasm. Previous studies have shown that gallium FAPI PET-CT delineated tumors and metastatic clearly with the high tracer uptake in a variety of tumor entities. Several authors has reported cases of cholangiocarcinoma detected with use of gallium FAPI-CT. A case scenario. A 53-year-old male was presented with EHBC, ERCP, and biliary stenting was done. This is showing the FDG-PET para-aortic lymph node, suggestive of left para-aortic lymph node, and ill-defined metabolic activity thickening at the level of gallbladder neck, extending to the porta and CBD. When biopsy was performed in the same case, the para-aortic lymph node was showing the adenocarcinoma, and breast cytology from gallbladder neck showing the malignant cells. This is the situation when this patient was treated by 3 cycles of chemotherapy. Here there is a disease present in this, and after post-therapy, the PET scan was done. There is no, this disease has shown the very good response to the treatment. So PET-CT imaging has rapidly emerging as an important imaging tool in oncology, but the success of the PET-CT imaging based on the patient get benefit of anatomical and functional whole body survey in a single session. We can detect out, and PET-CT provides a more accurate information than PET alone or CT alone. The PET-CT imaging gives better direction in deciding the treatment modalities. The oncologist with the functional information, status of the disease, and response assessment of the treatment delivered. In summary, use of FDG imaging in addition to the conventional tests like ultrasound, CT scan, MRI may be helpful in initial diagnosis and assessment of the current standard of care, initial assessment of the presence of the lymph node and distal metastasis. This may lead to identification of focal metastasis also, change in the management. This may lead to indication of lapse in patient with BTC as a guide treatment selection. The role of diagnosis of primary tumor remains controversial due to low specificity. 18F considered as a replacement, not to be considered as a replacement for pathological confirmation in this setting. Prognostic role of FDG-PET and impact of SU-MAX on management requires further investigation. Thank you, sir. Thank you. Here I want to add one more thing, sir, beyond this. FDG-PET is regularly being replaced by gallium FAPI because it gives a more accurate results and early detection. And we can start in the ILBS this with Dotanok, and there are some tracers. But we need to have some facilities and a pharmaceutical lab also. So we can start the FAPI as well as Dotanok and other relevant investigation if we recruit some faculty and technical staff for this. And as you have suggested, for dual tracer study also. My request is that, although I am not related to the nuclear medicine, but I little understand about the nuclear medicine, and I want to learn this through your blessings. So we can continue this program with your blessings if you and Dr. Meghna, we are losing a very good faculty, Dr. Meghna. So it is very painful. She was very good. Anyway, but we have to go with the time. Thank you very much, sir. And now I am